Yeah, very good afternoon. And today we are going to see the supraglottic airway device. I'm Dr. Sanmuga. Okay. Yeah. What is supraglottic airway device? Any idea? Yeah, supraglottic airway device is nothing but it is a device which is placed above the glottis to maintain the airway. So moving on to the topic per se, before that we should know what we are going to see in this class. We are going to see the history, how the LMA supraglottic airway device has evolved, and classification and their uses, and important points about the different supraglottic airway device. Okay. Then the history is, this is an important one mark for your exam, and so many things. So Archie Brain in London Hospital, he first developed the LMA in the year 1982. Yes, Archie Brain. It is the standard fixture in the airway management. As I told, no, it replaces the endotracheal tube. So we are maintaining the airway by using the supraglottic airway devices. Okay, this supraglottic airway device usually it fills a niche between the face mask and the ET tube in terms of both anatomical position and the degree of invasiveness. Okay, this device sits outside the trachea, usually just placed above the trachea, and provides a hand-free means of achieving a gas-tight airway. Okay. So then moving on to the classification. Based on the generation, how it is evolved. It is first generation and second generation. As you know, the first generation is the primitive one, and the second generation is the some modification in the first generation will lead to development of second generation. In first generation, it is a simple airway device with as a low ceiling pressure, and it has no significant design to lesser the risk of aspiration. Okay, main example is classical LMA and flexible LMA and ILMA. Okay, and few modification done in the second generation so as to have the superior one when compared to the previous one. Okay, here we have high safety index. It has a high ceiling pressure so that we can fit into the supraglottic space without the risk of aspiration. Okay, because whatever the gas we are giving, it should go into both into the trachea and esophagus. So if the ceiling pressure is high, there is a less risk of aspiration, and thus more efficacious in positive pressure ventilation. Okay. Usually first generation we can't give positive pressure ventilation. We can use it for a small case, and where we can maintain it in the spontaneous ventilation because of its low ceiling pressure. Whereas in second generation, we can use the LMA for even for major case. Okay, and we can give paralyze the patient, and we can give positive pressure ventilation. Here the main example is Procil LMA and LTS and IGL. We will see the pictures in the later slides. So first classification based on the generation is first generation and second generation, and based on the sealing mechanism. Okay, one is here we are using the cuffed sealer. Okay, based on the sealing mechanism, cuffed perilaryngeal sealers and cuffed pharyngeal sealers. In cuffed perilaryngeal sealers, here what we are going to see now, without direct sealing, usually cuff surrounds the laryngeal inlets and limits the sealing pressure like LMA, ILMA, and AMBO LMA. It has a direct sealing cuff from a seal to the inlet, and seals the pressure is improved by in case of Procil LMA. Whereas cuffed pharyngeal sealers, pharyngeal cuff seals at the base of the tongue without the esophageal sealing is Cobra LMA. With esophageal sealing is you can see in LT and LTD and combi tubes. Okay, in pharyngeal cuff sealers, usually it's placed at the base of the tongue, and it has some will goes into the esophagus and some goes just above the sealing with the esophagus and sealing without the esophagus. That means if you are putting the tube, it will go both into the esophagus. Okay. And there also we will put one cuff. And then is cuffless pre-shaped sealers. Okay, one is cuffed sealers and cuffless pre-shaped sealers. Here it seals the outlet from the base of the tongue right up to the esophageal inlet because of its tough wall. Okay, once if you are putting this, for example, is igel and Buska mask. Here it is already preformed shape is there, and you will be inserting this pre-shaped sealers, this igel into the base of the tongue and fit into the esophageal inlet. Okay, so that because of the tough wall, it's plastic, it will go and fit the inlet without any leak. Okay. Then moving on to the clinical uses of supraglottic airway device. It's usually used as an alternative to tracheal intubation. As I told, no, it is instead of intubating and putting the endotracheal tube into the trachea, here we are avoiding the trachea. We are just placing the supraglottic airway device just above the trachea, that is in the supraglottic space. Main thing, after the introduction of supraglottic airway device, it has shifted the paradigm from 2-choice to 3-choice model. It has more stability in hemodynamics, and also it has minimal effect in intraocular pressure and intracranial pressure. Okay, it has a lower incidence in emergence of cough and post-operative sore throat because we are not involving the larynx. Here we are placing the supraglottic airway device just above the glottis, so that it is not, we are not handling the endotracheal. Okay. So patient during the time of extubation, there is lower incidence of sore throat, postoperative sore throat, and also cough. Okay. And it also being used in laparoscopic surgeries. As I told, no, once the second generation has introduced, like LTS, so they are having very good pressure, sealing pressure. So with that sealing pressure, we can use this LMA for major surgeries and for laparoscopic surgeries. Okay, we can have lesser aspiration. Okay, we can prevent the aspiration because of its high sealing pressure. So main first use is it can be used as an alternate to endotracheal tube intubation, and it can be used as a tracheal intubation aid. Okay, along with this you can aid some other things also. I'll tell you, because it can be used for blind or fiber optic bronchoscope guided method to aid the endotracheal intubation. Fiber optic, so for putting the fiber optic scope, we can either go directly to the nasal or oral. We have to put one after sedating. We can introduce the fiber optic, and after putting the airway blocks, fiber optics, with the help of fiber optic, we can intubate the patient in the case of difficult airway. Or sometimes after the introduction of the supraglottic airway device, we can just maintain the airway by putting the supraglottic airway device. Then you can take your time so that you can introduce the fiber optic into the supraglottic airway device. Then once if you visualize the vocal cord, then you can remove the supraglottic airway device. Then you can put this endotracheal tube. Okay. Then blind tracheal intubation can be done after using the supraglottic airway device. Some devices are specially designed to aid the intubation. That is, intubating LMA is there. With that LMA, you can intubate. You can put the endotracheal tube also. You can put the LMA. Then with the help of introducer, you can introduce the endotracheal tube. Then once the endotracheal tube goes into the vocal cord, trachea, then you can, with the help of the guide wire, you can remove the supraglottic airway device. Then already you have put the endotracheal tube along the guidance of the supraglottic airway device. No, then you can intubate. Okay, can used as a tracheal intubation aid. Then in rescuing airway in the case of difficult intubation, failed intubation, and can't intubate and can't ventilate situation also. Because if you are not able to intubate or not able to ventilate, then after giving anesthesia, somehow you have to maintain the airway. No, in that case, what you can do, you can just put on LMA so that you can maintain the airway. Then, in case of difficult intubation and failed intubation, for that also we can use this. So, according to ASA, difficult airway algorithm has a prominent role for the use of supraglottic airway device. LMA has been shown to be efficient in preventing the significant desaturation in the case of pediatric patient with difficult airway. In case of intubating LMA, as I told, no, we have high success rate of blind and fiber optic bronchoscopic guided intubation. Then it can be used as in resuscitation and pre-hospital airway management. Airway management during the CPR has significant impact on survival. You know, because during CPR, airway is more important because you have to intubate, then you have to maintain the airway. Otherwise, patient will go for desaturation. Once desaturation occurs, vital organ perfusion and oxygenation maintenance is not be adequate. So for that, you have to maintain the airway during CPR. So in that maintenance, that to pre-hospital area where you can't get the laryngoscope or endotracheal tube or even the trained and skilled person. So in that case, you can intubate the trachea, difficult situation. You can use this LMA. Okay. So the main uses. So moving on to the main uses, clinical use. It can be used as an alternative to intubation and tracheal intubating aid. And in case of rescuing the airway, in case of difficult intubation, failed intubation, and can't intubate and can't ventilate situation. Okay, and also resuscitation in pre-hospital management. Okay, these are all the uses. And moving on to the indication. As I told already, it is an alternative airway during general anesthesia and patient requiring multiple anesthetics and during CPR to rescue the airway. It has been essential part during the difficult airway cut and also in professional singers where if you are intubating the professional singers, due to the intubation effect, sometimes they will have vocal cord edema or sometimes injury to the vocal cord. So in that case, if a singer had any accidental injury or any edema, their profession will get affected. So most of the singers, they won't want their voice to change following and surgery. So these patients, you can take them with the help of supraglottic airway device, okay, where we are not handling the trachea. We are just placing the LMA just above the supraglottic place, okay, in the supraglottic region, above the glottis. Okay, main indication. Once again, we can see it has been used as an alternative airway during the general anesthesia and patients who are requiring multiple anesthetics. And also during CPR to rescue airway, and it's an essential part during difficult airway cut and also in professional singers. Moving on to the contraindication, it limits the mouth opening. It has a limited mouth opening because at least you need 2-finger mouth opening so that you can insert the laryngeal mask airway. Okay. If the mouth opening is less than 2-finger, we can't put the supraglottic airway device. And also if there is any local pathology in the larynx or pharynx, you can't introduce the LMA. Once you need the space now, that supraglottic space is occupied by the mass lesion. So this device won't go and fit into the place. Okay. So in case of any local pathology on the larynx or pharynx, we can't use this. And in those patients who are having reduced lung complaints or increased work of breathing. And in few cases, we are handling the spine surgery or some other where we need prone position. We can't put the tube because we can't fix the LMA. And also in few cases where the patient who are having increased risk of aspiration in case of morbid obesity and pregnant patient whose pregnancy gestational age of more than 14 weeks and few cases who are having delayed gastric emptying in the case of laparotomy or any yes in the case of any perforation or intestinal obstruction whom they will have delayed gastric emptying, we can't take the patient under supraglottic airway device. So the contraindication is mouth opening limited to less than 2 finger, and any pathology in the larynx or pharynx, and patient who are having reduced lung complaints and have increased work of breathing, and in case of prone position anesthesia and increased risk of aspiration patient, we can't use them for supraglottic airway device. And moving on to the advantage, few advantages are, it has increased the speed and ease of placement. Okay, no need to wait for the drug to muscle relaxant to act immediately. Once the muscle relaxant is acted, then you can put the laryngoscope, then you have to visualize the vocal cord, then you have to put the endotracheal tube in case of normal GA with endotracheal tube. Whereas in case of supraglottic airway device, no need of putting laryngoscope or visualizing, just inserting the LMA into the supraglottic space. So it has an increased speed and ease of placement. It needs less expert, and it has main important thing is it has better hemodynamic stability during the induction and also during the emergence of anesthesia. It has minimal effect on intraocular pressure and intracranial pressure. It increases the airway tolerance. It has less chance of sore throat. Okay. Then moving on to the disadvantage, it has more chance of aspiration. In case of low ceiling pressure, patient will have increased chance of aspiration. And also in patient who are having vascular compression and nerve damage, we can't use them. And also in few cases who are having sore throat. So these are all the few disadvantages. Patient, there is having more chance of aspiration and vascular compression and nerve damage and sore throat. These are all the few disadvantages of LMA. So moving on to the care and cleaning. How will you care and clean the LMA? Normally we are using the LMA which we can reuse it. Okay, this reusable LMA should be cleaned with warm water and with dilute soda bicarbonate, that is 8% solution, and a pipe cleaner, that is a tube brush should be inserted to the distal aperture to clean the shaft. Okay, it has a shaft, no, that shaft has to be cleaned with a pipe cleaner. Okay, some brush has to be inserted and has to be cleaned. Normally LMA has to be cleaned with warm water and dilute sodium bicarbonate 8%. Okay, then the inflating valve should not be exposed to any of the cleaning solution, because inflating balloon, pilot balloon, if you are using any solution to clean, sometimes accidentally some material will go and lodge into the cuff. It will cause rupture of the valve. Okay, and liquid chemicals like glutaraldehyde, phenol, iodine solution, iodine containing solution, quaternary ammonium solution should not be used. Water should not enter into the cuff. Okay, these are all the important things while cleaning the laryngeal mask airway. You should not put anything into the inflating cuff, because the valve is there, no, that will get rupture. And chemical agents like glutaraldehyde, phenol or iodine containing solution should not be used. And also you should be very careful in the cuff, with water should not enter. Okay. Then moving on to the classical LMA. So this is the classical LMA picture. Okay, this is the classical LMA. It usually comprises of an airway tube. Yeah, this is the airway tube, and it has a mask. This is the mask and a inflating line. This is the inflating pilot balloon. Through this inflating pilot balloon, we are inflating the cuff. Okay. The mask is designed to conform to the contour of the hypopharynx with its lumen facing into the laryngeal opening. Okay, this is the lumen. It has to be face the laryngeal opening. It is usually made up of silicone with a sealing pressure of 25 centimeter of water. It has an elliptical aperture bar, and it has a universal 15 mm connector. This is the patient end. This cuff should face into the laryngeal opening. Okay, it has the airway. This is the airway tube, inflating pilot balloon which inflate the cuff, and it has the aperture, and this is the valve. You should not damage the valve while cleaning. Okay, and moving on to the various size of classical LMA. So how will you take the size? Usually according to the patient weight, we will be calculating the size, and based on the size of the LMA, we have to inflate the cuff. We can't blindly put, if it is a 7 size endotracheal tube, put some 5 ml of air. Not like that. Okay, you have to, according to the size, the volume of cuff should be maintained, and the size of the LMA is determined based on the patient weight. Okay, in case of LMA, there are 8 sizes. Size 1, it is used for neonates up to 5 kg, and its cuff volume should be 4 ml, and size of 1 to 1.5. This is used for infant of 5 to 10 kg, and its volume is 7 ml. You have to inflate. And size 2, children of weighing 10 to 20 kg. Its ml is, for 2 size, you have to inflate 10 ml, and 2.5 size you have to use for 20 to 30 kg, and with the volume of 14 ml. And 3 size is usually for 30 to 50 kg with the volume of 20 ml, and size 4 with the patient weight of 50 to 70 kg with a cuff volume of 30 ml. And size 5 is used in patient with 70 to 100 kg patient with the volume of 40 ml. And size 6, patients who are overweight, more than 100 kg, and the maximum cuff volume should be 50 ml. Okay, it has 8 sizes: size 1, 1.5, 2, 2.5, 3, 4, 5, 6. Okay, and it is used for the patient size of up to 5, 5 to 10, 10 to 20, 20 to 30, 30 to 50, 50 to 70, 70 to 100, and 100 and above. Okay, similarly, based on the size, we have to inflate the cuff volume. Okay. Then moving on to the preparation. How will you prepare the LMA for putting into the patient's supraglottic region? Okay. You have to select the appropriate size of LMA. As I told no the previous slide, based on the patient's weight, you have to take the LMA. Then you have to inflate according to the size of the LMA. Then once you have, okay, it is a, for example, it is a, it is a baby of 5 to 10 kg. You have to take the LMA size of 1.5 size. Okay, you have taken the LMA. Then you should look for any leak or any tear or any block in the cuff, and slowly deflate the cuff to form a smooth flat wedge. Okay, you have to deflate. Then you should not overinflate or deflate. Okay, do overinflation or deflation test, so that you have to look for any leak in the LMA. Okay, then use water soluble lubricant on the posterior aspect of the cuff just prior to insertion. Avoid lignocaine jelly, because lignocaine jelly causes sore throat. Okay, so water soluble lubricant should be applied on the posterior surface of the cuff. You should not put it in the laryngeal aperture. That opening you should not put, only in the back side, because that only you are going to place into the what? That only you are going to place into the heart palate, and through that way only it will go in and lodge into the supraglottic space. Okay, so main preparation, you have to take the appropriate size and look for any leak, tear, or any block, and slowly you have to deflate the cuff to form a smooth and flat wedge like thing. Then you have to check whether there is any leak by slow inflation and deflation test, and use water soluble lubricant in the posterior aspect just before inserting the tube. Avoid lignocaine jelly as it causes sore throat. Okay, this is how you have to hold the laryngeal mask airway. See how he is holding. He is holding like a pencil. You have to hold it like a pencil, and the aperture should be face above. Okay, then Put the patient in supine position. Just hold the neck. That's all. No need to put them in head tilt or chin lift. Jaw thrust is not needed. Just put the patient in lying down position. Hold the head. It should not roll. Okay, just hold the head. Then insert the laryngeal mask. So till the end, you feel one resistant. Till that time, see, this person is not removing his finger. Till it go and he felt some resistance. Then he has removed the hand. Okay. Then once, see, it has been lodged in the supraglottic space. Okay. Here you are seeing the tracheal opening. And here the esophagus. Posteriorly esophagus, anteriorly the trachea. This aperture is facing to the laryngeal inlet. And once you have put, then inflate. As I told, according to the size, inflation volume of air is also varies. Okay. So depending upon the size, appropriate maximum size volume of air should be inflated. Then slight upward movement of the tube upon inflation. So once after putting the tube, you have inflated. Then after inflation, you will be noting a small upward movement of the tube. Okay, and also you will feel a smooth oval shape swelling in the neck. And ventilate the patient with equal sound and base of the sound. And there should be absence of sound in the epigastric region. Okay. So after putting, inflate the tube and look for the oval swelling in the neck and auscultate the patient for equal of sound in both the lungs, both the chest, and look for absence of sound in the epigastric region. And the distal tip of the cuff, that is the usually it lodges in the upper esophageal sphincter. The side of the cuff in the piriform fossa. This is the piriform fossa. This side it is lodging the piriform fossa and the tip in the esophageal sphincter. And the upper part is in the base of the tongue. This is the base of the tongue. Okay. Like that it is fitted. This is the classical LMA I told. Now we are going to the Procil LMA. Procil LMA is usually a reusable LMA. It is made up of silicon. The main added advantage is here we are having one esophageal drain tube. See, you are seeing one hole, no? Through this one intragastric tube. You are seeing, see the parts, intragastric tube, and this is the cuff, and this is the back plate. This is the back plate, okay? And here one more hole is there. This tip only will lodges in the esophageal inlet. And this two sides lodges in the piriform fossa and this in the base of the tongue. Previous slide I told now how we are inserting and where this is lodges. So this added advantage of Procil LMA is main thing. It is a reusable one. It is made up of silicon. It has an esophageal drain tube and it has a double cuff. It has a posterior inflating cuff is also there. And it has a reinforced airway tube. It has a reinforced airway tube and it has an integrated bite block. See, this is the integrated bite block. Once the patient awakes, if they bite also, the tube won't get occluded. Okay, it has an integrated bite block. It has an introducer. It has a high leak pressure of 35 centimeter of water. Okay. Same thing. There's a connector, inflating pilot balloon, wire reinforced airway tube, and the intragastric tube is there. So that you can, this is the intragastric, external gastric tube. This is the internal gastric tube. This is the tip of the gastric tube. You can put on Rayleigh tube so that you can aspirate the intragastric fluid or air, whichever gets collected during the procedure. Here it is also having the same way, various size, 1.5, 2, 2.5, 3, 4, 5, 6. Same what I told for the classic LMA is same for the Procil LMA also. Only difference is it has a double cuff, integrated bite block, and an added advantage of gastric port, intragastric tube and external gastric tube, so that you can introduce the suction tube or a rice tube. You can aspirate the things. Okay. Then advantages of classic LMA over the Procil LMA. As I told, no, it has a gastric tube posteriorly, gastric access and checking correct for it, whether it is in correct position. Okay, and it has a dorsal cup for better sealing and airway pressure. It has an integrated bite block. It has improved airway sealing pressure during the positive pressure ventilation. And disadvantages over classical LMA, more incidents of trauma and longer insertion time. It needs some time because it has two tubes, no, 20% more airway resistance, as you can note, and less suitable for intubating device, because we can't intubate with an blind intubation or fiber optic tube. We can't put because it has a reinforced tube inside. Then this is LMA of unique. This is a single use, whereas Procil LMA is, it is a reusable thing, whereas LMA unique is single use. It is made up of, that is made up of silicon, whereas this is made up of PVC. It is cheaper one. The tube is stiffer. It has cuffless compliant. Less rising intra-cuff pressure with nitrous oxide. Size is same as CLMA. I don't know, 1.5, 2, 2.5, 3, 4, 5, and 6. Then this is flexible LMA. Same like classical LMA, it is flexible. You can just flexibly, you can fold so that nothing will get kinked. Tube won't get kinked. It has a narrow and longer flexometallic tube. Sealing pressure of 20 centimeter of water. Difficult to insert because it needs an introduce, because it is flexible. Now you can't hold it and introduce. Difficult to dislodge. Once you have inserted properly, it is very difficult to dislodge, and useful for all head and neck surgery, ENT, and upper dorsal surgeries. Main disadvantages: disruption of the wire, increased airway resistance, that is limited endoscopy and ET tube pass, and it is unsuitable for MRI. This is the LMA. This is a cuffless pre-shaped. Okay. Pre-shaped thing is IGEL. This is the IGEL. This is LMA. Okay. Laryngeal mask flexible LMA, and this is IGEL. Cuffless pre-shaped. There is no cuff. This is you. Who has introduced? That is introduced by LMA is introduced by Archibald, whereas IGEL is introduced by Mohammed Nasser. It has single use. It has cuffless use. No cuff. I told you there is no cuff. It is a single use. The mask is made up of some soft thermoplastic polyester, and is shaped similar to that of an inflating LMA posteriorly, and anteriorly designed to fit the perilaryngeal structures. Okay. It has narrow bore esophageal drain tube is also there. Integrated bite block is option for only size 1, whereas rest all the thing there is an integrated bite block. And epiglottis usually rest on the anterior part of the mask, which reduces the possibility of downfolding of the air and airway obstruction. Okay. Whereas in the other thing, there is downfolding is there. It has a better anatomical fitness and improves its airway sealing as it approaches the body. Main thing is, according to our body temperature, the thermoplastics, the thermostat, no, it is made up of, as I told, what is that? Thermoplastic polymer. It swells and go and fit into the airway. According to the body temperature, according to the temperature, that thermoplaster will get swells and go and fit it into the anatomy. Okay. It has less risk of injury related to the cuff. Hyperinflation decrease the time of successful insertion. Okay. It has less risk of injury related to cuff hyperinflation and it has decreased the time of successful insertion. Okay, because here the tip doesn't roll over the epiglottis. IGEL is in meta-analysis has found to be having a greater airway leak pressure and superior fiber optic view can be compared to that of other supraglottic airways. Wide lumen allows for intubation and also airway rescue. It is effective for even for prone position because it is made up of that thermoelastic plaster. No, that thermoplastic elaster go and fit into the airway. Then moving on to the cobra LMA. You see, this is looks like a snake. Okay, cobra. You know, no snake. This is the head and this is the tail. See the head, tail. Mainly, it is single-use plastic device. It has a high volume and low pressure oval shaped cuff. Okay, high volume and low pressure oval shaped cuff. The cuff usually fit into the hypopharynx at the base of the tongue. Okay. Then moving on to the esophageal tracheal combi tube. Esophageal tracheal combi tube. Okay. This it has a two lumen. As I told, proximal cuff and distal cuff. Distal cuff usually large in the esophagus. Proximal cuff just above the laryngeal inlet. So two inflating pilot balloons are there. It is made up of PVC double lumen with two inflating cuffs. Usually ventilation either through the tracheal or the esophageal port. You can ventilate through either of this. The distal balloon enters and seals the trachea or the esophagus. Main advantage, it requires the minimal training and minimal mouth opening. Very useful in non-fasting patients during emergency because it go on large into the esophageal inlet. Okay, the distal cuff, as I told, no, that cuff go and fit into the esophageal inlet. Then disadvantage, sometimes if you are putting the cuff too much in the esophageal trauma, only adult size is available. One more problem, and the problem with minimal with maintaining the sealing effect. Okay, it is a PVC with two inflating tubes, cuffs, and usually ventilation through the trachea or esophageal port. We can do either of this. Distal port usually either seals the trachea or the esophagus. Main important advantage, it requires minimal training, and even with lesser mouth opening, we can introduce it. Even with non-fasting patients during emergency time, we can use this. Whereas the main disadvantage is the distal esophageal trauma. Because of the distal port inflation, esophageal trauma can occur. Only adult size is available, and there is a few problems with maintaining the sealing pressure. This is the laryngeal tube. That is combi tube. This is laryngeal tube. This also has two cuffs. Okay. It has multi-use single lumen. It also has two cuffs, two low pressure cuffs, distal and proximal, and two anterior oval ventilating port between the two cuffs. Two oval ventilating ports between the two cuffs. Okay. Main advantage, it has an easy insertion. Minimal mouth opening is required, and high ventilation pressure can be used. Can be used to intubate the trachea. Okay. Main disadvantage, trauma to the pharynx. Cuff sometimes can rupture. Airway obstruction can occur, and narrowing of the airway can occur. Okay. Then this is also one of the cuffless preformed shaper. Okay. This is SILPA, streamlined linear of the pharyngeal airways. Okay. Streamlined linear of the pharyngeal airway. See the parts. It has a toe. This is the heel. It's look like our foot. This is the leg. This is the foot. Imagine. So stem. In the foot you are having toes, no? Toes and heels. And hollow chamber. And this is the bridge. Okay, so these are all the parts. It has a stem, heel, toe, bridge, and a hollow chamber. And moving on to the LMA of fast track. LMA fast track are otherwise known as intubating LMA. What is an intubating LMA? See, this is the LMA, and here we are putting the endotracheal tube into the LMA so that it is coming out through the aperture. Here the aperture you can lift, whereas in the classical LMA you can't lift the aperture. So if you are able to lift the aperture, then you can insert the tube so that the tube will come out and go and fit into the laryngeal inlet. Okay, it's like a spoon, silver spoon. Then C-track LMA. What is C-track LMA? This is, we are viewing the image in like video laryngoscope, you know, no? Same like you are using the C-track LMA. Similar to that of fast track LMA, usually to build up a fiber optic channel. Okay, this is fiber optic channel you can build up, and monitors are attached and a magnetic to a magnetic latch connector, and it is available in 3 sizes. Poor image quality than flexible fiber optic because we can't see it. Some kind of fadeness you can make out. Okay, so as a revision, you can see special igel. Okay, this is the igel image where there is no cuff. This is the cobra. It is a single-use plastic device. No, this is also having cuff. This is the combi tube. Here it has the distal cuff and proximal cuff and 2 lumens. One is going to the, this is for trachea. This is goes to the esophagus. Okay. This is the laryngeal tube. In laryngeal tube, this is having very faster intubation rate. Even for head and neck surgeries, you can use. This is the streamline linear of pharyngeal airway. Same like our foot. You have to put it just inside. No other special maneuver is needed. Okay. And fast track LMA, this is a more interesting thing. Here, just introduce the LMA, same like a normal classical LMA. Once you have introduced and ventilate, then you have to remove the connectors. Here only they will be connecting. No, you have to remove. Here only they will be connecting the vein circuit, so that you can give the oxygen to the patient. This is the patient end. This is the machine end. Then once you checked out whether it has been fitted properly, then bilateral air entry has to check. Then after checking it, disconnect the LMA from the ventilator. Then introduce the endotracheal tube with the help of the guide wire. Then once this has been introduced into the endotrachea, then you have to insert the guide wire and remove the LMA posteriorly. Then check the bilateral air entry. Once the air entry is confirmed, then remove the LMA and fix it. Okay. No need to put scope for this. You can put the LMA of fast track, or same other name is, what is the other name? It is intubating LMA. That fast track LMA, then you have to put the endotracheal tube. This is the C track LMA, same like fiber optic. We can visualize the glottis. Once if you visualize the glottis, then you can put the endotracheal tube. Okay, as a summary, so first who has found out the LMA? It is Archie Bain in the year 1982. Then who has found out the IGEL? Mohammed. Yeah, he is Mohammed. So once history you know, then you have to go on to the classification. There are so many classification based on the generation, first generation, second generation. You should know what are all the advantages of first generation over the second generation. You should know. In that first generation, what is the main disadvantages? Their sealing pressure is low. So that because of low sealing pressure, more chance of aspiration is there. So they have developed some modification in that, and they found out the second generation with a high sealing pressure, so that you can make the patient for longer duration of surgery, and you can give positive pressure ventilation in that. Okay. Then moving on to the next. Yeah, it is cuffless, cuffed perilaryngeal is there. Then preformed shaper is there. Then what are all the indications? Main important indications is used as an aid for endotracheal tube intubation. In the case of difficult airway, can't intubate, can't ventilate, you can use this LMA where you doesn't need a much training. Even a paramedics can use the LMA. And also in few places where mouth opening is small, at least you need, even if the mouth opening is less than 2 finger, you can't use this LMA. At least 2 finger mouth opening is needed for introducing this. Okay, in case of post-burn contracture whose mouth opening of less than 2 finger, you can't use this. Otherwise, we can use this LMA. Okay, yeah. Then some other thing. Then what we have seen, what are all the advantage and disadvantage? Because of the recent newer generation, they are having integrated gastric port and integrated bite block is there. These are all you are seeing it in ProSeal LMA, whereas classical LMA we are not having that. Then what we have seen, main advantage over the other thing is here we are just placing the LMA just above the supraglottic space. We are not handling the, yes, we are not handling the trachea. We are just placing above the trachea. Okay. So we can use this LMA for singers. Main important thing there, post-operative sore throat. Few patients will complain of sore throat in the case of endotracheal intubation. Whereas in LMA, there is less chance of sore throat and less chance of increase in intraocular pressure or intragastric pressure. And we have better hemodynamic stability. Intubation stress response is not there because we are placing above the glottis. Yes. Okay. So advantage, and combi tube plays an important role. Combi tube it has 2 cuffs. One is proximal and distal cuff. One will lodge above the larynx and one above the esophagus. Okay, so that if you want to ventilate the pharyngeal larynx, you have to put the 2 cuffs. Then you have to auscultate whether you are able to hear the air entry in both the lungs and there should not be any air entry into the stomach, epigastric region. If it is so, then your thing is in correct position. Okay. Then C track LMA, so many newer advantage. Okay. Yeah. Thank you.